Welcome, everybody. We're excited to welcome everyone to our forum today to kick off our Wear Red Canada events here at Toronto Rehab. So we're excited to welcome Dr. O, but before, we just wanted to thank our planning committee here at Toronto Rehab, who has been incredible in helping get our events planned and basically presenting. We have a whole calendar of events that are happening over the next few weeks and lead up to February 13th, Wear Red Canada's national event. And beyond, we have a few others, so please be sure to check our calendar of events. But this team, as you can see, is mighty and many. So thank you again for everyone who has been a key part of planning this year's events. Okay, so without any further ado, I'm going to welcome our leader, our medical director of the Toronto Rehab University Health Network Cardiovascular Prevention and Rehabilitation Program to present today cardiac risk factors in women.
Great.
Thanks, Paul.
And thank you very much. And welcome to Tracy Colella. Dr. Colella has been very much involved with the entire national efforts in the Canadian Women's Heart Health Organization. And so thank you very much for transferring that leadership to our program. And indeed, we've got a fantastic team with us within our program to champion Wear Red for 2023. In the room, we've got, it looks like hundreds and hundreds of people in the room, all of whom are separated, of course, physically, being COVID compliant, but we're delighted, sort of separated, but we're delighted that we can actually have a somewhat live event, and we're really happy that many of you are able to join us online as well. So thanks for that. The outline for this session, we're going to take about 35 minutes or so to go through this topic to kick off our Wear Red Canada local educational series. And the topic that was we thought that would be useful was to describe approaches to assessing what is our risk. And we have a mixed sexed audience, but predominantly women in the room. So the right sex is represented. There'll maybe be something for the men in the room as well, but appropriately very little, so that's okay. But we will start with a discussion on commonly used models for CV risk assessment, and then importantly, their limitations, which then leads to why do we need to think more broadly about other clinical indicators? And then most importantly, what are the specific risk factors that are important for assessment of heart disease risk in women in particular? And we'll touch on some approaches for prevention. And I'm feeling like I should do a big apology at this point because it's me who's presenting on this topic of women's heart health, but I feel privileged to be amongst you to simply facilitate this discussion. Okay, so if you'll allow me to continue, quick check in. Yeah, okay, Larry, let's keep going. So why do we care about risk? Because you want to be entertained while you have pizza, right? So why do we care about risk? So there's a few reasons why we might want to do this in a thoughtful way. And the first one might be, we want to know our risk to reassure ourselves that we're doing all the right things because we want to live for a long life, a healthy life, a quality life. This is great. But sometimes there are risk factors that will emerge. And it's good to identify where there might be issues that we can actually surface and manage so that we can live a long and healthy life. And then for some people, there may be opportunities for us to think about other therapies that we want to lay in. And risk assessment can help us along the way in helping make some of these decisions. So let's start here. I think, quick poll of the room. Who's heard of Framingham risk scores? Yeah. The questions won't get any more challenging than this. So thanks for that. In the room, there was good endorsement of that. Online, I hope you can do the same thing. I can't see you, so I can't see your hands. Well, let's assume. Sharon, raise your hand. So Sharon's heard of it. Thanks, Sharon. So of these questions regarding Framingham, I ask you to ponder. Which of these things is true? Item A, Dr. Martha Framingham was a leading cardiologist who was appointed Surgeon General in the US for her pioneering work in public health. Is that true? Or does Framingham, is that an acronym for factors for risk of acute myocardial infarction, global harmonization score? Or C, Framingham is a town in New England, in Middlesex County, in Massachusetts. It was important in the anti-slavery movement and also the site for the Framingham study. You could do this kind of in your own heads. I did this live in a few conferences. It's actually quite fun. So who would vote for A, Dr. Martha Framingham? Any takers? B, Framingham acronym? Or C, Framingham, New England? Okay, so we had 5 people that voted in the room. Thank you. 5 people were brave enough to declare that Framingham is indeed a town in New England. The other ones sound very plausible, don't they? But they're not real. Okay, so Framingham is a risk score. It's based on a town. And for those of you who are familiar with Framingham, most of you are, how do you feel about Framingham? Tell us how you really feel. Not that you really feel about risk factor models, but do you use Framingham and you love it because it addresses all of those important risk issues: cholesterol, smoking, blood pressure, diabetes, age, sex. It's perfect. You love it? Or do you use it really because that's what's in guidelines? Or are you concerned about it because there's some things that are missing? Or do you really feel like I need something else? Okay, and that's Sharon raised her hand again. So Sharon, I'm thinking that you think there are better risk models. I love the answer. So the truth is, everything is correct. The truth is, when I ask a bunch of docs this, they may not love it, but they use it because they don't have anything else. And that's where we're stuck. And by the end of this, I think we'll all say D is probably the right answer here, but I don't have a better answer for you in the moment, but maybe some ideas. So Framingham, 1948, happy 75th Framingham, that's when this study started. It's like Stepford. Remember the Stepford Wives, captive little town. Everyone lives the same, eats the same, breathes the same, married to the same people. So that's Framingham. There were 5,000 people that were recruited in 1948, and everything about them was tracked subsequently. Every 2 years, how are you? How are you eating? How are you moving? Have you had a heart problem yet? And that continued on decade after decade after decade. And now they're into their 3rd generation cohort of this. So that's exciting. That's powerful. You got a whole town that you can follow, but there's the inherent limitation. Are you or the people who you manage similar to the people who are captive in Framingham? If yes, this is a perfect model for you. If no, then maybe you need something else. And that's going to be the hypothesis here, right? This is the terrible slide that shows you what Framingham is about in like a tabular format to risk. But the idea is that you look at the major domains that are shown in the red box. How old are you? What sex are you? Biologic sex with its limitations, cholesterol levels, blood pressure, diabetes, smoking. And that's what we would all have said, that these are the big risk factors for heart disease. Why? Because Framingham has been telling us this for 75 years. And it's pretty good. Obviously, the higher you are on any scale, the more your risk is going to be over time. So an older person, particularly an older woman who has high cholesterol, high blood pressure, diabetes, yes, and who smokes, is going to have the highest cardiovascular risk. And that's pretty good. That gets the conversation started, okay? So if we use this profile as someone who will look at a few times using different calculation methods, let's think about this in our own heads. If we were helping to look after a 58-year-old woman, or if you are a 58-year-old woman who has the following cholesterol, total cholesterol is 4, the LDL cholesterol is 2, not bad, HDL cholesterol 1.2, pretty good, blood pressure 128/84, not bad, not smoking, no diabetes. What's your gestalt on this? Is this person high risk, medium risk, or low risk? Okay, in the room, we've already got, probably low-ish risk, right? 58-year-old, good cholesterol, good blood pressure, non-smoking, no diabetes, probably low risk. The Framingham calculator will ask us to assign risk points to every one of those domains. So the major risk for this individual is that she is in fact a 58-year-old woman, but everything else does not give her any risk at all, that she's deemed to be kind of ideal in all of those domains. Add up the points, put it on the grid, you get a 10-year projected risk of 6%, which is low. And that's helpful for our discussion. We would say, Madame, you are low risk. Let's reassure you. You should eat well. You should move more. You should manage stress. Do all the really good things in life. But if the question was about putting you on cholesterol medicines or aspirin or anything else, the answer would be no. We don't need to do those things. Carry on. Live a good life. The points, though, are that Framingham could be a good start, but there are limitations. And it works pretty well for this 58-year-old. But if she was 78 or 28, it really doesn't work well because there weren't a lot of those people in Framingham at the time that the equations were developed. There was not a lot of ethnocultural racial diversity in Framingham 75 years ago. So we don't have a lot of information about what happens in other populations. And in fact, when people try to validate these risk equations in other populations or in other parts of the world, they don't line up so well. So people with heart disease score low. Some people that score high on a Framingham actually don't have heart disease. So it gets kind of confusing in that way. And what about psychosocial factors or health behaviors? Where are they in this equation? And the answer would be, it's important, but Framingham didn't look at it. They didn't think that those were important things 75 years ago. And most importantly for today's discussion, there is nothing about sex-specific risk factors in any of those models. So talking about some health behaviors and risk, for instance, the folks in our cardiac rehab program are very familiar with this kind of information. Like there is a very important relationship between your chance of dying and your levels of fitness. Higher levels of fitness will protect you from death in an extraordinary way compared to people with low levels of fitness. And that's true for men and it's true for women as well. So fitness really needs to be in these risk models. They are hardly ever in any risk model though. So that's an important limitation. The flip of the coin of fitness and activity is how much time you spend sitting. And of course, you are all putting yourselves at incredible risk right now. You know that. That's okay. The pizza, that cancels it out, I'm sure. But there's these relationships that would say the chance of dying over 4 years relates in a big way to how much time we spend sitting, right? So where is that in Framingham risk models? No one thought to measure it at that time. And what about things like food? Just picking on something like a Mediterranean pattern of eating, that we know that over a 5-year period of time, people who follow a healthy pattern of eating, fruits, veggies, fiber, extra virgin olive oil, lots of it inside of you and outside of you, will have a much lower risk of developing heart attack, stroke, and dying. Where is the food pattern in risk equations? It doesn't exist. And then other smart folks like Paul Ridker from Harvard wrote about novel kinds of risk factors that aren't so novel anymore, but the idea that inflammation, things inside of us, are also important in developing heart risk. And other folks develop alternate risk scores, like this thing called Reynolds, that has in it one of the important components is highly sensitive C-reactive protein, an inflammation marker. And the idea is that if you have a higher level of CRP, that means things inside of you are quite angry, will attack parts of your body, including your coronary arteries. So you need to know that as well to determine risk. And indeed, if you look at large cohorts of people, including large cohorts of women who might be kind of falling in the middle, if you look at CRP, you can recategorize, calibrate, get a better idea what's going on with people. So some of the women that were kind of in the middle would say, based on a high CRP, you're really high risk. Based on a low CRP, you're really low risk. So it's an important differentiator that we might understand. Mental health, of course, is really important. It's not in Framingham. We know as a rough rule, depression doubles the risk of death post-MI. MI doubles the risk of depression, and on it goes. We're aware of unique syndromes like Takotsubo cardiomyopathy, so-called octopus trap heart, a kind of heart attack, heart failure related almost exclusively to stress. Looks like a heart attack, your heart gets transformed, affects predominantly women. So these are important things that we can also think about that are not in Framingham. And then thinking more globally, because we already made that argument, it matters a lot where you live in the world. Geography is associated with different risks. And of course, there's those associations. It's not that one country is inherently riskier than another, but tied to population risk factors, sociodemographics, education, availability of healthy environments and food and pollution, all of these things will drive risk. So it's important to know where you live to look at risk as well. So if we think about some of those factors and redo our risk calculation for our 58-year-old woman who lives in Canada using a World Health Organization calculator, well, we can see that her risk would be deemed to be 10% as opposed to 7%. So we're getting to a finer level of this. So is there a better model that we might think about? And when I did this session a few months ago at the Canadian meeting, we looked at other kinds of risk models available in other countries. And in the UK, they've developed a broader, more comprehensive risk model, considering the diversity of the population who lives in London. Arguably, that's very similar to the diverse population who lives in Toronto and elsewhere, hopefully for folks online. So that now, if we start to enter in other things like ethnicity, presence of other risk factors like kidney disease or atrial fibrillation, or if you've got migraine headaches, or if you've got other conditions like rheumatoid arthritis or lupus or depression, look at not only what your level of blood pressure is, but whether it goes up or down or changes a whole lot. And what is your BMI? Then you get something through this engine that's called Q-risk, a much more refined estimate of risk. And that our 58-year-old woman who looked to have very few risk factors now seems to have a risk that's gone up 3 times by being more granular about all the things that she is coping with, which is very interesting, right? So risk calculators are always only as good as the ones we pick. And ideally, we have picked the calculator that matches the population. Okay, so that's one message. And then this is one of our more favorite Canadian style of risk calculators. And this is something that you can do. I did this at a conference, and then at the break, everyone was just comparing how long they were going to live. Very depressing, but they're very excited about it. So after this session, go to projectbiglife.ca. You can figure out how long you will live, what your risk of a heart attack in the next 5 years will be, and also how much salt that's in your diet. So that's actually kind of fun. The heart attack and stroke calculator, the reason that we like this one, it's Canadian, but it also is one opportunity to start entering in some of the health behaviors like smoking, alcohol, and how many fruits and veggies that you get to take in per day. And fun fact, have a potato a day, take a year of life away. Oh, I presented this in New Brunswick. They kicked me out of this conference. So to have some fun with that. And more importantly, you can start to play with, are there other things in my life that I might think about modifying that could affect how long I live, how well I live? So there's some fun ones. On the topic of women, because that's what we're here, there have been many models. There's 285 published models at the time of this publication, which was a couple years ago. 285 different ways of predicting whether women are going to have a heart attack or not. We've discussed 3. And we could show that the risk is either 7% or it's 21%. It's either low or high, depending what you throw into it. There's 285 other ones. I haven't looked at them all, but some other smart folks did. The point I want to make here is there's lots of models, but only 2 out of 285 actually looked at factors that are actually important to women. Interesting. So what are those factors that we want to talk about? Here's an excellent reference for you as a takeaway. A couple of years ago in the journal Circulation, so the big cardiovascular journal, there was a kind of a primer and education one that talked about sex-specific factors in the assessment of women's cardiovascular risk. So there's a good takeaway. I've drawn some highlights out of that. This is the infographic that speaks to it, that there are issues that women face throughout their lifespan And that's kind of an important concept, that risk is not just a one thing, it's a whole continuum, and it's over the time course of a person's life. That early in life, in our younger years, we may experience events that might start to elevate risk. Like, what is the time of menarche? How old was a person, a woman, a girl, when menarche started? And that will influence the trajectory later on. Was there use of contraceptives, hormone-based contraceptives? Are there other kind of comorbid issues like polycystic ovarian syndrome? During pregnancy, what's going on? Were there any events like high blood pressure or diabetes that occurred? What was the outcome with delivery of hopefully healthy babies? But sometimes there are other events like having babies are too early. My older son was born at age 36 weeks, so he spent his first couple of weeks. So fun fact, that these things happen. Good outcomes happen, but we have to think about them as markers along the way where issues may arise later on. And then around the time of menopause, that if menopause goes on or happens early, that might denote a risk that's going to happen later on. So let's dive in a couple things here. Some people have coined the term pregnancy as a natural stress test. And for those of you who might have had an experience, you can say yay or nay, whether that's true or not. Stress is of some sort. The direct quote from the paper, it's a time that's ripe. I don't know why they use that wording, but it's time that's ripe for gathering data on cardiovascular. Did anybody do that during a pregnancy? Oh, I think this is a good time to assess my heart disease risk. While I'm in labor, yeah. Adverse pregnancy outcomes such as high blood pressure at the time of delivery, or gestational diabetes occurs fairly often, right? 3% to 20% of pregnancies. And each of these conditions has been associated with heightened cardiovascular risk. Preeclampsia is that event where blood pressure goes up, urine spills into protein. After 20 weeks of gestation, it becomes an important concern. And when blood pressure goes up and stays up through pregnancy, that's another kind of event that is associated with elevating risk downstream for long-term high blood pressure, diabetes, but also for developing heart problems like heart attack or heart failure. Developing diabetes during pregnancy is an important issue as well. And if you develop it during pregnancy, then it may portend the development of diabetes later on in life. And this may also then cascade into higher cardiac risk. Developing a baby too early or delivering a baby too early, not by choice, but if that happens, then it's thought that this is also then associated with developing blood pressure, high cholesterol, and then developing atherosclerosis earlier on than we might want to. And same for small babies, small for gestational age. And the notion here is that if the baby is unable to grow to full capacity, then maybe this is like the stress test as well, that kind of this baby was restricted, our heart capacity is somewhat restricted, and that this may predict the future cardiovascular risk. As we alluded to, early menopause or ovarian failure, maybe because we lose protection of estrogens early on, that those women who develop menopause before the age of 45 compared to those after the age of 45 have a higher risk of heart disease subsequently. And this other syndrome where hormonal balance is off in a number of different ways. Polycystic ovarian syndrome is associated with excess androgens, irregular menstruation, and also associated with high blood pressure, insulin resistance, higher cholesterol, metabolic syndrome. All of these things sound very familiar for developing heart disease. And then this overlap that occurs, of course, in women, because we know that breast cancer is common in women, sadly. Heart disease is common in women, sadly, and then there's an overlap that it can occur as well. That we know that some of the treatments that are offered for breast cancer may actually increase the risk of developing heart disease subsequently. Dr. Rivera will be doing a lovely session on this in this upcoming series. There are also many shared risk factors between heart disease and cancer that we won't go into right now, but also importantly, there are ways of dealing with this in a combined way, and we're delighted that the program has spent a lot of time and effort and has wonderful expertise with our health program. So Danielle and Christine and Geraldine's not here today, but there's wonderful experts who can lead us in these combined programs as well. And then shout out back to Dr. Ridker, who talked about this notion of CRP. Well, C-reactive protein is high in conditions like rheumatoid arthritis or psoriasis or lupus. And these are conditions where there is inflammation going on. Inflammation on the skin, like red, angry skin, may also transfer to red angriness inside of us, and that can accelerate the development of heart disease. Wow, that sounds really terrible, doesn't it? That's a bummer. Oh, thanks for coming out. Appreciate it. Yeah, great. So there's lots of things that we need to consider, and that was really the main part of this, that it goes a much further than thinking about cholesterol and blood pressure and diabetes and smoking, that there's many other risk factors. And I, for one, have been very appreciative of the opportunity of being able to learn about this because of you. And then on the protective side, one good thing, so we have to talk about one good thing. You know, breastfeeding is good for so many reasons, but breastfeeding is also really good because it can actually lower your risk of developing heart disease because of really good things that happen metabolically, in addition to immunity, bonding, mental health, etc. So coming back to this kind of lifespan infographic that talks about all of these events, and I'm grateful to our leaders, women leaders in our program who have been championing the idea that a complete medical history for our women involves a good examination of this as a continuum. So thank you very much for doing that and continuing to lead the charge on this, because we're going to do as thorough an assessment as we can so that importantly we get to these kinds of steps to success. So I think this is the pattern that we're following that comes from the American Heart Association as ways that we can reduce risk in women. So one is awareness. Thanks for coming out. We can look at a long list of sex-specific risk factors, and we only know about it if we ask about it. And if you lived in Framingham, they would never ask you. They probably do now because they're very smart. But 75 years ago, they would have never thought that any of these things were important for women or for anybody else. Step two is that once you've done the sex-specific ones, let's look at the regular ones: cholesterol, blood pressure, diabetes, smoking. And if you've got any of those things going on, then coupled with step one, that makes us want to be a bit more aware, a bit more aggressive about beginning management, where we get to step number three. The American Heart Association's Life's Simple 7 are the things that we do in all of our practices. Here in the room, we're representing cardiac and neuro rehabilitation, the people whom we see and work with. These would be some of the mantras that we deal with of blood pressure, cholesterol, sugar, active, healthy, losing weight, and stopping smoking. And then at the far end, we'll be thinking about where we need to intensify drug therapies as necessary. Okay, coming to the end of this right on time, 12:30. So the summary, we started in a little town in New England called Framingham. Dr. Framingham was not there. Framingham is not an acronym. Framingham is a town. It's okay to start in Framingham, but we go broader, and we're cosmopolitan in Toronto and surrounding area, and we need to look at our entire population. So we will match the risk assessment to the populations whom we're serving. So just remember that Framingham can be a start, but it might be way off. We want to look deeper and consider novel factors, other established risk markers, because that's going to help us come to a better plan around treatment. Importantly, we already do it in spades of looking at health behavior and psychosocial issues, that those are really important topics for us. But now, my commitment to myself, if I'm thinking of a learning objective for this session for myself, is that I'll think more deliberately about sex-specific risk factors, commit to taking those histories, inquiring in an appreciative way about what's actually happening over a lifespan, and thinking about ways that we might actually kind of act to help reduce risk. Okay, thanks for that. I'm going to stop my share at this point, and we're going to invite in the opportunity for comments, questions. So folks online, if you will enter in your questions through the Q&A, that would be really much appreciated. And folks in the room, let's start here. Thanks, Bonnie, for kicking us off.
I was just curious, have you encountered any studies that relate to taking information from like the Apple Watch? There's so much data that's collected. I'm just curious if there's anything that take all the reams of data from all the women who wear that kind of technology and data.
Okay, so thanks, and Bonnie, I'll for the benefit of folks online, I'll paraphrase your question if I may. The question is around, are there any studies that look at the use of wearable devices and gathering of health information and the relationship to health outcomes, and what's the deal there? And I think it would be fair to say that we're at the crux or the beginning of where we're going to get some really good information about that. I would be remiss if I wouldn't say, hey, we got a study for that about what's going on with our people who are participating in cardiac rehab and what happens to health outcomes down the road. That's exactly the study that we're engaged in. So Jess and Simi and Mackenzie, Lais and others are championing that study. Lisa and Lais are finishing off a study in that domain. But there's other big ones. You know, Apple has done studies with hundreds of thousands of people looking at various aspects of health, heart rhythms, what goes on with temperature fluctuations and menstrual periods. And you're right, you can look at all kinds of movement, balance. In the stroke world, it'd be very interesting to look at gait symmetry and what happens with risk of falls, for instance, heart rate data, heart rate variability, fitness levels. So this is going to be very exciting. But I think it's fair to say that we have not seen a lot of like definitive studies at this point, but it's going to be exciting. And as we move to both on-site and remote rehabilitation, that there's going to be terrific opportunities to leverage wearables so that we can better understand what's going on and also to deliver rehab in a different way to be even more effective. Dr. Najawan. Okay, thank you. And for benefit of folks online, Dr. Najawan, who is one of our original champions of women's heart health in the program, even before there was a Wear Red campaign, we had Dr. Najawan. So thank you, Dr. Najawan. And Dr. Najawan's question is around whether we should be thinking about cardiovascular risk more broadly and bringing women into the program based upon sex-specific risk factors, even if I'm paraphrasing correctly, even if their blood pressure might be okay or the cholesterol might be okay, or if they've not had a heart event. And that's such an exciting idea. Yeah. Like a primary prevention program, exactly, wonderful. And you know, an example would be our breast cancer class as an example of it's secondary prevention after cancer, but it's primary prevention of heart disease in a way. We've been running programs for people living with diabetes in a way, but you're absolutely right that maybe it's time for projects like the one that Dr. Colella and Dr. Cody have been championing for a while around looking at women who've had an issue during pregnancy. So developing gestational diabetes or gestational hypertension. We know that probably right afterwards, they're going to be fine. Blood pressure goes down, diabetes goes down, but over the next decades, the risk will go up. So is it time for a project in that kind of population? And the answer is absolutely. There's lots of enthusiasm for this. I think the challenge for us is to choose where we spend our energies and our focus. But it's wonderful to think along these lines of how we can develop programs. And the answer may not be all bricks and mortar, bring them in for rehabilitation on site. there may be other ways of engaging with population for these broader health initiatives. And I think we're excited to look at that. Okay. Turning online for a question, we have a couple minutes still. A question from one of our participants who was wondering, is there a place that does research after heart disease has been identified that shows data about the medication used and the complications caused? So if I paraphrase for myself, because I just like to hear myself talk, that, I think the concern is around medications and their side effects, which is absolutely an important issue. And when we have question and answer periods with our patient population, this is usually the theme that comes up around either direct adverse experiences or concerns about adverse experiences. And this is really important for us to identify. Is there research about adverse complications? Absolutely, but there's lots of kind of data about known side effects and from various medications. There are things that we know about that happen with certain meds in a dose-dependent fashion. There are also unusual events that sometimes are harder to detect. It's important to have those conversations. If you're experiencing, or if you're feeling unwell, chat with your pharmacist, chat with your doctor, see if this is the most appropriate medication for you, see if there might be an alternative instead. Probably a deeper conversation would require something outside of this forum, but we do appreciate you bringing that up as an important domain for us. Dr. Cody.
Let's ask an opinion question. We know that numbers of women in cardiac rehab are low. Hard thing to get from the board. I'm wondering what your opinion is on ways to overcome that barrier. Like, what do you see as ways we can improve that?
Thanks, Lisa, for the question. For the folks online, the question was about what do we think about ideas in encouraging more women to participate in cardiac rehab? For information of the groups who may not be working in the space, that typically about 30% of our population participating in rehab is comprised of women. It's true for cardiac rehab. There's probably a sex gap in stroke rehabilitation and other types of medical care as well. There's been lots of great research, much of it brought from our program scientists, some of whom are in the room, some of whom are not in the room, that have identified barriers like time and need to support family, therefore don't support themselves, other kinds of social constructs that make it more challenging, lack of referral, lack of endorsement by healthcare providers, reducing barriers in program by making it as welcoming and comfortable as possible. So I think that there's many things that we can look at from end to end across the system. I think what we have not done yet, Lisa, is actually look at this in a very strategic way across the city, for instance. Let's make this campaign about how can we bring in more women into the program and look at every facet of the referral, entry, participation process. We can do things on our end, but if nobody comes, then we're stuck. So we've got great programs on site, women's only classes, facilitated education, great supports, but we still need more people to come across. So I think this is a great opportunity for us to do more work in that space. In certain research domains, the teams have done excellent work at identifying participation of women as a priority and have launched some very specific initiatives that way with good success. We need to do the same thing with our clinical programming. Okay, anything else, anybody? Questions online, offline? No. Okay, so let's end it up there. Okay.